Okay, welcome to the, I think it's now the 5th lecture. And today we're going to do broad complex tachycardias, moving on from narrow complex tachycardias last week. I'm Dr. Sandilands, you all know me. So hopefully got this talk to join in. So again, thank you for listening in. The ECG is a highly difficult skill to become a master, and certainly students are going to learn at different paces, but certainly practice of ECGs makes perfect. It's a bit like playing a musical instrument where you need to practice to get better. It does help to have context in the clinical years, but this can confuse sometimes, but there's normally some history around when you get given an ECG on the wards in real life or even in exams. So today, we're going to identify broad complex tachycardias and know about the causes. These are probably the hardest bunch of ECGs that you will have. They could be related to focal areas, so ectopic beats. Focal, all the beats will look the same shape. Reentrant around scars, possibly. And also they could be life-threatening. So again, we want to understand the key concepts relating to the signals on the ECG, how we interpret them to get the diagnosis of the ECG correct. So I want to be able to improve your confidence ECG interpretation by the end, and hopefully we're trying to do that gradually before next week's last lecture, which is a revision lecture. So we're going to start off with Kahoot to look at some of the concepts on the ECG, review the ECG signals again that are pertinent. We talk about this evening SVT with bundle branch block, so where there's pre-existing bundle branch block, when the heart goes fast, there is still bundle branch block. So by definition, it's a broad complex tachycardia, but it's an SVT with pre-existing bundle branch block. The other thing is aberrancy. I'm just letting 2 more people in. Just turn off your microphone, please. So the other thing that we need to think about is aberrancy. And aberrancy is something which is a functional bundle branch block, meaning that as the heart goes fast, the bundle branch block appears, and when the heart slows down, the bundle branch block disappears and the heart goes back to being a narrow complex. But I'll show you some examples. We're going to look at Wolff-Parkinson-White again, but more of the broad complex tachycardias, so those going forwards over the pathway where there will be evidence of a delta wave. And lastly, ventricular tachycardia. And we'll look at the algorithm for broad complex tachycardias to try and help you interpret them and become more confident. So we'll go through lots of examples this evening. And at the end, we'll do a bit more Kahoot. So let's try and go to Kahoot. Oh. Where are we? Just trying to find Kahoot. So sorry about this. Just where's the, for some reason it's there. Oh, here we go. Sorry about this. I was just trying to. Okay. So. Okay, so if you want to join in, we're just going to look at some concepts of broad complex tachycardias. Hopefully you can see this. The gain pin is 5393209 if you want to join in, please. Okay, let's get started. I'll just wait another few seconds. Yeah, so greater than 120, remember, 3 small squares. The QRS has to be greater than 3 small squares. Yeah, so if bundle branch block is present, then an SVT will present as a broad complex tachycardia. So not only with all Parkinsonite, if bundle branch block is present. Okay. Yeah, so this is left bundle branch block. Yeah, so right bundle branch block. Okay. So we've done questions 1 to 4. So we're going through this all again to keep going through this. And that's the main point of this, to try and repeat ECG so you get used to the pattern. So we have a QRS being prolonged here. This is not a tachycardia. It's just an ECG showing sinus rhythm. Heart rate's about 90. But when we go through your basic algorithm, you will see that the QRS is prolonged. So in V1, it's a very prolonged QRS. There's the start of the S. There's the start there. So it's at least 4 squares, at least. And the pattern is that it's negative in V1 because it goes below the isoelectric line. So that alone would tell you it's left bundle branch block. But we look at the other things. Sometimes in left bundle branch block, or mostly, there is left axis deviation. So AVL is the most positive. We don't get a transition again until it being positive until V5 or V6. So that would be typical of left bundle branch block, but mostly with the signal in V1. So this means that the signal, the bundle is blocked here. The signal has to go first to the right ventricle. And then when that depolarizes, it can then get to the left ventricle. That takes longer, hence the QRS is long. So we've talked about this before. Just to recap again, we've got three sort of phases of signal in left bundle branch block. As I said, you've got block, so no electricity can flow down the left bundle. It has to go to the right bundle first. This is what depolarizes first. So we have a very small segment going towards V3, okay, going away from V1 and V2, or perpendicular anyway. Then the right ventricle depolarizes, getting ready to go towards the left. And therefore this is this deflection going towards most of the lateral leads. And then lastly, the full depolarization of the left ventricle is the greatest deflection going towards V6 as the most positive lead. Okay, so this is left bundle branch block, negative deflection V1, normally a positive deflection in V6. Alternatively, we go through our basic algorithm again. Again, this is not a tachycardia. I'm trying to get you used to the bundle branch block signals so that if you see these signals, these typical signals in a tachycardia, then you may be able to diagnose SVT with bundle branch block. So now we go to V1. You've seen this ECG before. We've got a very wide QRS, and we've got signals with a bunny rabbit's ear, which is small, followed by a big bunny rabbit's ear. And this pattern here is consistent with right bundle branch block. Right bundle branch block. It's above the isoelectric line. It's positive. Let's check if we got right bundle branch block. Okay, the axis is normally normal, but you've got a slurring of the S wave in AVL and a slurring of this S wave in V6 to confirm that we have right bundle branch block. Right bundle branch block. So again, the right bundle is blocked. Electricity has to flow to the left first, then to the right, and that takes longer. Hence, the QRS is wider. So again, just to compare those signals, we're really looking at V1 as our main objective for being left bundle branch block and being negative. And V1 again, if it's positive, with the two bunny rabbit's ears, one small, one big. Sometimes the small bunny rabbit's ear is very small, so you have to look very clearly for that. Okay, any questions so far? Okay, on to the next group of questions. Yeah, aberrantly conducted. Aberrantly conducted. I don't want to say anything else. I can't remember the next question, but yeah. So right bundle branch block when it's fast, typically right bundle branch block, although it can be left bundle branch block, versus a normal QRS in sinus rhythm. But this is wrong. So narrow QRS when fast, right bundle branch block when slow. No, it's the other way around, okay? Because so it's going from being fast, a functional bundle branch block, where you see right bundle branch block, the right bundle is not working for the time the heart is fast. When the heart slows down, the right bundle starts working again. Okay, so what we can see here, I'm just showing you here that this is an example of one beat of aberrant conduction. So we have a normal QRS here in V1, V2, V3. We have an ectopic beat, an atrial ectopic, conducting with a very small R and then a QRS that looks like right bundle branch block. So this is what we call one aberrant beat because of an atrial ectopic occurring early. But otherwise, and there's one there, you can't tell it's right bundle branch block here. There is some slurring But yeah, there is a beat there that is probably aberrantly conducted. That's just one beat. Okay, so there's the atrial ectopic, aberrantly conducted. At that point in time, the right bundle is not ready to take it, and so portrays itself as a right bundle branch block. On that beat, it recovers back to sinus rhythm, and then there's a narrow QRS. Another way of showing you this aberrant conduction is to look at this ECG. So there's a continuous tachycardia. So we're going to concentrate on V1 and V5 here. I think it's V5. And there's a seamless tachycardia going from left to right. So it's going here and then going across here. Completely seamless. It doesn't stop, it carries on. So what this shows is on this half of the ECG is a broad complex. On this side, there's a narrow complex, but it's going from broad to narrow. And if we look a little bit more detail at these signals in the V leads, you've got a little bump and a big bump. Again, a little bump and a big bump here, okay, in these leads to suggest that this is right bundle branch block, right bundle branch block. And as it's fast or during this rate, there is right bundle branch block. Now the right bundle says, I'm okay again. I'm going to switch back on and I become narrow complex during this phase of the tachycardia. So you know that this is aberrant conduction because the tachycardia is seamless and goes from being broad into narrow without stopping. You could go the other way, it could go narrow into broad complex, and if it's seamless going the other way, that is still aberrant conduction. So it's just a functional bundle branch block that's occurring when the heart is going fast. It's not dangerous, it's not abnormal, but it's just a concept where the right bundle switches off. Normally, it can be the left bundle as well. Any questions about this concept? Okay, so remember, it's a tachycardia where there is a functional bundle branch block, normally right more than left. It can be either. We see right bundle branch block tachycardia, and the heart is fast going into narrow complex tachycardia, or it could be the other way, narrow going into broad. But when we look in V1 or V2, we see the typical bunny rabbit's ears and the broad QRS here to signify right bundle branch block. So that's why I keep showing you right and left bundle branch block, so you're used to the pattern of what that looks like. Okay. Here is another example. So we have two ECGs from the same patient at different time points. On this, we have a tachycardia. It's regular, it's broad, and we have a RSR, as we call it, or a small r, big R in V1. So we're looking at being positive, QRS, broad. So it's a right bundle branch block. It's a typical right bundle branch block pattern. Okay. So this is fast in SVT, but then they go back to normal rhythm when the heart is slower. There is a normal QRS. So we know that this was aberrantly conducted SVT, aberrantly conducted SVT because of the right bundle branch block pattern. And you can only say it's aberrantly conducted once you know they're back in a normal rhythm and they have a normal QRS. Any questions? Any questions about aberrant conduction? Okay. Questions 7 and 9. 7 to 9. Yeah, so it's a delta wave. The delta wave signifies conduction. I don't want to say anything else for the next question. So it's conduction from the atrium to the ventricle. From atrium to the ventricle over the pathway, you will see the delta wave. Only conduction from the atrium to the ventricle over the pathway. It's only atrial fibrillation. We'll talk about this, so don't worry, it doesn't matter that you got it wrong, but it's only atrial fibrillation that will conduct forwards over the pathway. This AV node reentrant, nodal reentrant tachycardia is within the node itself, so it doesn't come near the pathway. Orthodromic atrioventricular reentrant tachycardia is narrow. You do not see a delta wave. VT, you do not see a delta wave. So tricky question, I admit, but trying to test your understanding. But let's go through that now, don't worry. So accessory pathways, as they're known as, or the syndrome of Wolff-Parkinson-White, is an accessory pathway and palpitations. So basically they can present in a few ways. Normally, electricity flows from the sinus node, AV node, to the ventricles via the drawbridge of the AV node. In these patients, though, they have an accessory pathway or a bridge, so conduction can go forwards over the pathway. In this example, there is a tachycardia where the electricity is flowing down the AV node and back up the pathway. Okay, so in sinus rhythm in this patient, there is a PR interval that's very short. There is the slurring of this S wave, which is the delta wave here, the quick conduction. They have very quick conduction from over the pathway or accessory bridge. But when this patient is in tachycardia going down the node, back up the pathway, it's a regular, narrow, complex tachycardia. There is now no delta wave because it's going down the pathway, down the node, back up the pathway. You do not see a delta wave during tachycardia in this example. However, so this is the example we've just looked at in a different form. So going down the AV node and back up the pathway to re-enter the atrium, because it's re-entry, you will have a narrow complex tachycardia. It's narrow complex. If we then switch the tachycardia the other way, and it's now antidromic, we have conduction over the pathway very fast, because these are very fast conductors this way, down to the ventricle, back up the AV node, because you're going forwards from the atrium over to the ventricles, over the pathway, you now see a delta wave. Okay, so this tachycardia is broad, but there is a presence of a delta wave. Okay, so presence of a delta wave means you've got forward conduction, the tachycardia is going from the atrium to the ventricles. That example is atrial fibrillation. Any questions? Okay. Oops, sorry. Yeah, so the sinus node continues firing at its own normal rate. Okay, it does not, it doesn't do intermittent firing. It's not the same rate as the VT at all, and it doesn't stop firing. Okay, so sorry, there was a question in the chat that just came along. Sorry, could you go over why you get a delta wave again, please? Yes, of course. Okay. So let's just go back. So you only get a delta wave when you have conduction going forwards over a pathway, this way. In actual fact, let's do this. Okay, so hopefully you can see this now. Let's say, so typically our pathways, 70% of pathways are on the lateral mitral valve annulus. So this is the left-hand side, this is the right-hand side of the heart. Okay, so what happens when you get a delta wave? When do you get a delta wave? So in sinus rhythm, so the sinus node, the AV node, the right and the left bundle. So when will we get a delta wave? So in sinus rhythm, the beat goes to the AV node next, but electrical depolarization will mean some of it goes down the pathway and goes down to the ventricle that way in sinus rhythm. So in sinus rhythm, because it's going forwards over the pathway here, and it's quicker here than it is here, then you'll have a short PR interval and the slurring slurring, which is the delta wave here, of that conduction going over the pathway. Okay, short PR interval and the slurring. Okay, so short PR interval here, the slurring is the delta wave there. Okay, so going down the pathway there. So when it goes forwards over the pathway, that's the only time that you see conduction going forwards over the pathway. So it's in sinus rhythm. Okay, let's just go back a little bit. The other time that you get tachycardia with a delta wave is basically in antidromic tachycardia. So now they generate a tachycardia where it goes down the AV node, goes into the ventricles, goes up the AV node, re-enters the atrium and goes back round again. So this is a fast tachycardia. It's regular. Okay, so when you see the tachycardia, you have a delta wave, next beat, delta wave, next beat, delta wave. Okay, so you see the delta wave because the conduction is going, there's the delta wave there, delta wave here, delta waves there. Okay, every time you see a delta wave, because it's going forwards over the pathway from the atrium to the ventricles, okay, and going round, re-entering again. This is antidromic tachycardia. So because it's going this way around, you'll see the delta wave. If it's going the other way around, if I draw it in a different color, if the tachycardia is going down the AV node and back up the pathway this way to re-enter the atrium and going down the node again, so it's still re-entry, it's orthodromic. The tachycardia is narrow because it's coming down the AV node and back up the pathway, so it becomes narrow. There's no delta wave. You just have a regular, there is no delta wave at all. I know it's a bit faster, and so it's regular, there is no delta wave compared to the delta wave being there. And lastly, the last time we see a delta wave is if there is either atrial fibrillation or atrial flutter. So I draw atrial fibrillation like this. We'll do it in this color. The top chamber is in atrial fibrillation. It's fibrillating very fast, okay, or atrial flutter in the top. So where does this atrial fibrillation go? It can go two places. It can go down the AV node, yeah, or it could go down the pathway, which is very quick at conducting. So down to the bottom of the ventricle. Okay, so quick conduction down. So basically, if the top chamber is going 300 beats a minute, the bottom chamber could also go 300 beats a minute. And this is why patients with War Parkinson White can die suddenly, because they go into VF. So we see atrial fibrillation going down pathway into the ventricles, making the ventricles go very fast and risking VF. But now you have a delta wave because it's going forwards, but you have an irregular rhythm. It's very irregular and fast. But there's evidence of the delta wave all the time in that part there, delta wave, delta wave. So you see a signal of the delta wave because the atrial fibrillation is going down forwards over the pathway. I hope that answers it for everyone. Okay, yeah. So it's only when you see conduction going over the pathway forwards from the atrium to the ventricles. Okay. So we'd finished that. Where is the best place to see P waves during VT? Okay, so 4 of you have gone with 4 answers. The best place is actually lead V1. V1 is at the top of the chest, if you look at my chest, and then V1's here. You're seeing the atrium probably, you know, at that area, and that's where V1, you're going to see the sinus node beating in VT at a different rate to the ventricle is beating. Yeah, so it's called fusion and capture beats. Don't worry, we're trying to test concepts. It doesn't matter you get it wrong, you're learning and we're trying to teach. So I think that was the last one, we'll just see. Well done, S. I'm just going to stop that. Get back to the... Okay, so let's just have a look at VT now. So we're going to talk about this in a bit more detail. So how do we tell? How do we know that SVT with right bundle branch block versus it being ventricular tachycardia from the left ventricle? There's a few things that we can look at to try and say. In this example, we've just got, again, another close-up of the small bunny rabbit's ears in a normal rhythm, sinus rhythm, small bunny rabbit's ear and a big bunny rabbit's ear. So this is a broad QRS, V1 positive above the isoelectric line. This is right bundle branch block. Okay, if we're trying to look for a difference, so looking at the beginning of the R to the bottom point of the S wave, and if that's greater than 100 milliseconds, then we're dealing with a beat that's ventricular tachycardia, and we don't have 2 bunny rabbit's ears, we normally just have 1. Okay, the other way around, looking where there's left bundle branch block, okay, so we're looking at the R wave in left bundle branch block. When it's aberrant conduction, the R wave is normally very narrow, but when it's VT with a left bundle branch block pattern, because it's coming from the right ventricle, the R wave is wide. Okay, and we've got this nadir from there to there is over 100 milliseconds, and therefore this beat would be a VT beat. And I'll put 2 beats together that are trying to show the difference between left bundle branch block with aberrant conduction and VT. Okay. So how can we tell it's ventricular tachycardia? So this is an example of what we call dissociation. Dissociation means it's the opposite of when there's complete heart block, the complete opposite. So the ventricle is beating very fast. You can see that this is lead V1. You've got a big bunny rabbit's ear and then a small bunny rabbit's ear. So that's the other way around. Conveniently, I put the arrows where the sinus node is firing. And it seems to be roughly every 2 beats of VT that the sinus node fires. Okay, so you can see the sinus node is just firing. V1 is the best place to see this. So it's firing on its own independently, and then the VT just carries on going very fast at the bottom. So this is what we call VA, ventricular atrial dissociation. It's pathognomonic of VT. It makes you confirm that there is ventricular tachycardia. Okay, so how can we look at that? So I just want to show you, hopefully you can see this. So this is an operation of a heart, and it's going to just let it play. This is VT, the ventricle. It's actually VF actually. And there's the sinus, there's the atrium, and there's the sinus node beating completely different rate ventricle. You see that? So this is VT, this is sinus at a different rate. So it's dissociated. This is fast. There's no relationship between the V and the A. Any questions on that? Okay, so that's VA dissociation. When we see VA dissociation, so when there's evidence of VA dissociation, that is pathognomonic of VT. Okay, so looking in lead V1 is the best way to look at that. Okay, the other thing that happens in VT is something called fusion and capture beats. So when the sinus node does beat, it might collide with a VT beat, causing fusion, almost squashed together. It's a different beat to the VT. And if the VT slows down enough, the sinus captures the AV node and causes what looks like a sinus beat. Okay, sinus beat, and then the VT carries on again. So they are fusion and capture beats. Again, if you see those in a tachycardia ECG with a broad complex, you know that you have ventricular tachycardia. Again, they're pathognomonic of ventricular tachycardia. So let's look at the concepts again we've talked about. So just to recap, supraventricular tachycardias that we talked about last week with bundle branch block will give you a broad complex tachycardia, but in particular in V1, it will be either left or right bundle branch block. So look for V1, look at the typical bundle branch block pattern. So the question is, you see a regular broad complex tachycardia. Is this a typical bundle branch block pattern? So left bundle branch block, check V5 and V6 for positivity. There may be left axis deviation. Is there SVT with aberrancy? Is there this functional bundle branch block only when the heart goes fast? And when the heart slows down or goes back into a normal rhythm, you then have a narrow QRS. And it's normally right bundle branch block more than left, but it can be either of these. So the transition is seamless between the tachycardia where it's broad and narrow. Okay, or you can say it's aberrant conduction when the tachycardia has bundle branch block and the sinus has a narrow complex. But a typical bundle branch block pattern. Where else can you get a regular broad complex tachycardia? We've talked about when it's Wolff-Parkinson-White, when it goes down forwards over the pathway from the atrium to the ventricles and back up the AV node to re-enter the atrium. So there will be a presence of a delta wave. And lastly, ventricular tachycardia, which will not show a typical bundle branch block pattern in V1. There may be evidence of VA dissociation in V1. There may be fusion and capture beats. Okay, so these are regular broad complex tachycardias. SVT or narrow complex tachycardia with pre-existing bundle branch block, SVT with aberrancy, Wolff-Parkinson-White with antidramic tachycardia, and VT. Okay, any questions? So let's just go back. I just want to try and describe, before we look at the ECGs, I want to describe with pictorially what we mean by fusion and capture. Okay, so let's pick a color. So sinus node, AV node, right and left bundles. So let's just say we've got a scar here. Okay, let's make it red. So there's a scar in the muscle here. This patient had a heart attack years ago. They've got a small scar. Okay, let's try and. So the scar is imperfect. If you look at the muscle, the scar is imperfect. It has little channels in it, actually. So try and draw it properly to try and explain things. So it's not a perfect scar, and this is why we get ventricular tachycardia. So the depolarization comes here, it goes into the scar, come out the scar, okay? So this is a patient that will have a broad complex rhythm, okay? And you'll see that on the ECG. It will not be a typical bundle branch block pattern. So how can we tell it's VT? There's two ways. We look at the sinus node firing. When the sinus node fires, okay, it will fire independently, and so we'll have a P wave going along at about 80 beats a minute, for example, okay? So when we look in V1, we might see evidence of a P wave, but that's independent firing, and we have to mix that with the VT occurring. So this is the VT, regular broad complex tachycardia. Okay, so let's put them together to make up V1. And so you've got to imagine now that the P wave is, this one is in there, so you're not going to see it. That one's at the beginning, so you might just see it here. This one's in there, so you might see it in there, and that you might get the tail end of that one. So when you're looking in V1, the best ECG, you see this evidence of dissociation. So there's V's, lots of V's. You can't always see the P wave, but you're getting an idea of the P wave rate here by looking at these two signals, okay? And that will give you your sinus rate. And when you have that, that is pathognomonic of ventricular tachycardia. Okay, so that's just another pictorial indication of VA dissociation. What about fusion and capture? So the VT occurs. Sometimes the sinus node will come along, and because the VT is happening, it won't do anything. There's just the VT occurs, there's depolarization of the heart from the VT going along, and the sinus node hits the AV node. There's nowhere for it to go because the ventricle is depolarized. Sometimes the VT might slow down enough that the beat hits the AV node, comes down into the ventricle, and then collides with the VT. It manages to go over the AV node, collides with the VT, and gives us what we call fusion. So fusion beat is sort of like a medium-sized beat. So it's neither narrow, so it's not narrow, like in sinus, and it's not broad, like in VT. So it's like a narrow beat, these two squashed together, and this is called fusion. So when you're looking at an ECG, it's a regular broad complex tachycardia, okay? You're looking for fusion beats. Again, it might be pathognomonic. Invariably, you don't normally see them, but you are looking for them to prove that it's ventricular tachycardia. Okay, so that's fusion. The last thing that may happen is that in actual fact, the sinus node hits the AV node, the VT is slowed down within its scar, so it hasn't come out of the scar yet. It hits the AV node, and it actually conducts all the way down both the bundles, and therefore gives a capture beat. So it's captured the ventricle fully, capture. And basically we have you'll see this P wave and a narrow QRS, okay, before it goes back to being the broad beat of VT. Okay, so there's the VT starting again. But this beat here is our capture beat as the sinus node captures the AV node, depolarizes down because the VT circuit is slowed down, perhaps within its scar. So any questions about those concepts, please? Okay, so let's go through the ECGs then. So we're on the right side of the tachycardia algorithm now because we're dealing with QRS being broad. Okay, QRS being broad. So we know it's greater than 3 small squares in tachycardia. We ask ourselves, is the rhythm regular or irregular? If it's regular, then we must think it's VT, but we have to prove it otherwise because VT can be dangerous. Okay, but regular broad complex tachycardias might not be VT. If we do think it's VT, can we corroborate? Can we say, okay, this is more likely to be VT if there is a pattern that's not like bundle branch block? So look at V1. Is there fusion? Is there capture? Is there dissociation? Is there concordance? So concordance means that there is all the chest leads are either negative or all the chest leads are positive, but it's not mandatory. If you don't see fusion, capture, dissociation, concordance, it can still be VT, and VT is your bottom line. You always think it's VT until it prove it otherwise. So you don't have to, it doesn't have to be mandatory to see those things, but you look for those things to corroborate it being VT. Alternatively, we see a delta wave, as I've said, and we've got the Wolff-Parkinson-White antidromic tachycardia going down the pathway and back up the node. Or are we dealing with SVTs, all of these, with pre-existing bundle branch block? So we see a typical bundle branch block pattern in V1, or do we have SVT with aberrancy? Alternatively, we have a QRS being broad and irregular. It's an irregular rhythm. So now we look at the QRSs. Are the QRSs large or normal amplitude and discrete? So if they are discrete, do they have a typical bundle branch block pattern? If they do, then we know it's atrial fibrillation with bundle branch block or atrial fibrillation with aberrancy. Are there fast rates, and the rates are up to 300 beats a minute with varying QRS morphology and a delta wave? Then we've got atrial fibrillation pre-excited, which is atrial fibrillation and Wolff-Parkinson-White. Okay, atrial fibrillation pre-excited. If the QRS is broad, irregular, and discrete, but variable shape, then the things it might be, and I'll show you some examples, don't worry, it's torsades, twisting, polymorphic VT, many forms, or a bizarre QRS 10-T, hyperkalemia, which can be a tachycardia. And then lastly, is the QRS broad, irregular, very disorganized, or chaotic QRSs, very flat, it's ventricular fibrillation. So let's just try and go through those. Any questions about the algorithm before I move on? Okay. So I'll go through these ECGs for you. This is an ECG. Okay, it's sinus rhythm. It's not a tachycardia, obviously, but I'm getting you to look at V1. Okay, so we've got a P wave. We've got a broad QRS. This is broad. So we think about bundle branch block. It's negative in V1. Yes, it's towards the left axis. It doesn't become positive till V5 or V6. Okay, but this is in a normal rhythm, in the resting state. This is left bundle branch block. Now, this same patient goes into tachycardia. So you've got a tachycardia. So we go through the algorithm. Is the tachycardia narrow or broad? It's certainly broad. Look at that. R to S is greater than 3 small squares. R to S is greater than 3 small squares. And we look at our pattern. Look at the pattern here. We can see that the V1 is negative. This is a left bundle branch block pattern. Yes, we've got some left axis deviation. And yes, we've got positivity in V5 and V6. So this looks like tachycardia with left bundle branch block. Now, the one thing to do here is just try and scan. I'm going to flick between the two ECGs to try and show you and look at one lead at a time. So look at V1. Sorry, I'm going to click on it. Look at V1 and look at V1 now. V1 now, V1 now, V1 now. Look at that. They look the same, don't they? This one, on this example, is just sped up because the patient is in tachycardia. They still have bundle branch block. Look at lead 1 and AVL now. So they go back and forth. 1 and AVL, yes, they're positive. 1 and AVL are positive. Lead 2, oh, sorry, wrong way. Lead 2 is negative. Lead 2 is negative. So look at 3 and AVF now in normal rhythm. 3 and AVF are negative, yes. Let's look at V5 and V6. Sorry, wrong way. V5 and V6 are positive, yes. So you can understand now this patient in this state in a normal rhythm has left bundle branch block. When they speed up, they still have left bundle branch block because all the QRSs match up, and this is just their tachycardia. So this could be an SVT like AVNRT or AVRT, but in the presence of left bundle branch block. Okay. In a similar way, we've got this ECG showing, again, a broad QRS with the bunny-rabbit being small and large, a very wide QRS, slurring in AVL, and yes, wave in V6. So we know this is right bundle branch block. Let's see what happens to this patient when they go into tachycardia. So this patient goes into tachycardia. We have the small bunny rabbits here, the big bunny rabbits here. It's a broad QRS. It's regular. It's a tachycardia. Okay. So in this V1, the small, then the big is likely to be right bundle branch block, and it matches the right bundle branch block V1 in the sinus ECG. So now we're flicking again. If you look at all the leads, they all match up in their shapes. Okay, they all match up. Again, we've got the slurring in AVL and in V6 of the S wave to say that this is right bundle branch block tachycardia. It could be aberrant, but if we have an ECG when they go back into sinus rhythm, we know that this is not. This is pre-existing bundle branch block. Any questions? Okay, so we're sort of talking about QRS broad, regular, typical bundle branch block pattern. We've talked about this SVT with right bundle branch block and VT from the left ventricle, looking for the big R waves, wide R waves, I've shown you this before to show you that we have tachycardia seamlessly going from left to right, and there is a right bundle branch block pattern here, okay, going into this tachycardia, which is narrow. Because it's seamless, the transition does not stop and it restarts. This tachycardia has to be aberrantly conducted, and this is narrow complex tachycardia. It could go the other way, it could go narrow, going into broad, which would be the same. As long as it's a seamless transition, you would say that this is aberrantly conducted. Okay, so now we're on to the different part of the algorithm. We've got this ECG, which is again a resting ECG. So AVL is probably the best lead to look at here. If you look here, we've got a short PR interval, very short. Okay, it's less about 100 milliseconds. We have a slurring of the R wave here. Again, you see this slurring here in lead 1, and it's positive. When it's negative, you have a negative slurring. So you can see that's a delta wave, but a negative delta wave. Okay, there's another delta wave. So this is a patient with a delta wave. They might have all Parkinson-White if they have tachycardia. That's a syndrome, but this is the delta wave. So in the resting state, they have a pathway that's conducting from the sinus node to the ventricles via the pathway. We've talked about when they get, this patient would get narrow complex tachycardia when it goes down the node, back up the ventricle, up to the accessory pathway, re-entering the atrium. Alternatively, they would have a regular broad complex tachycardia with a delta wave if the tachycardia goes forward over the pathway to the ventricles, re-enters the atrium via the AV node, back up to the atrium again to go back round. So this is just another way of showing you these different tachycardias. In normal rhythm, there is pre-excitation, which is another word for saying there is evidence of a delta wave. So short PR interval. When the tachycardia goes down the node and back up the pathway, we have a narrow QRS. There may be a P wave after the QRS, which is signifying activation of the atrium after the tachycardia going back into the atrium. And then lastly, antidromic AVRT again, when it's going down the pathway, back up the node to re-enter, and there's evidence of this delta wave. Again, just recapping all this for you to make sure you understand. So when we look at tachycardias now, this is just a rhythm strip of a tachycardia that's regular. It's regular. You can look at the QRS heights, look pretty the same as you go along. You've got a negative delta wave here. You've got a positive delta wave in there. Okay. So this is evidence of antidromic tachycardia. It's just the limb leads only, but it's just evidence of antidromic tachycardia in this patient. So it's broad complex tachycardia, regular, okay, and evidence of a delta wave. I'll just give you some time to look at this example. So we have a tachycardia. The ways to approach these ECGs is not to worry. So this is a tachycardia. It's regular. It's broad QRS. Okay, so when you get a broad QRS, let's go to V1. Is this a typical bundle branch block pattern? Alone, just look at V1 on its own. No, the bunny rabbit's ears, if they are bunny rabbit's ears, are the wrong way round. Okay, so we don't think this is a typical bundle branch block pattern. Next question, is there a delta wave? So let's look along in the leads. So when we're looking at these leads, yes, I say there's a delta wave here going up like that. And so this is evidence of your antidromic tachycardia going down the pathway and back up the node. Okay, antidromic tachycardia going down the pathway, back up the node. Have a look at this example, please. Okay, so in this example, we have, I brought it into this area of the discussion, but we have a tachycardia, okay? We have a broad complex tachycardia, but it is irregular now. The spacing becomes different between each QRS. And also the QRS heights actually are variable, okay? And it's irregular. So do we see a typical bundle branch block pattern in V1? No, we do not. Do we see evidence of a delta wave? Yes. So you can see that these have a sort of partial delta wave, but this is full pre-excitation of the delta wave. Okay. And so this is an example where there's atrial fibrillation. There's variable QRS heights. It's penetrating down the pathway by evidence of a delta wave here. There's a delta wave there, delta wave there. So it's going down the AV node and through the delta waves. These are pure delta waves. Okay, and you can see it's very fast, 300 beats a minute almost at times. Okay, and that's where the 300 beats a minute comes in with the tachycardia. So this is atrial fibrillation going down the pathway to the ventricles, and it's very risky. In this situation, you electrically cardiovert the patient to make sure they're safe. You do not give them any medication that blocks the AV node, because then you'll send more of the signal down the pathway to the ventricles. Wolff Parkinson White, this is atrial fibrillation with pre-excitation. Pre-excitation is another word we use for saying there's the presence of a delta wave. Any questions? Okay, so we've done QRS broad, bundle branch block pattern, delta waves. I've talked about AF being pre-excited just to match that in with the delta waves there. Okay, so narrow versus broad, aberrant conduction, Wolff Parkinson White can be narrow complex, broad complex with a delta wave, pre-excited AF with a delta wave. There is no delta wave in narrow complex tachycardia. Okay, let's move on a concept. Okay, so we're going to show you a series of ECGs, and I sort of made the same sort of concepts with atrial tachycardia. Okay, so now we're going to talk about this ECG. So we look at the rhythm strip. We have a normal sinus beat and then a broad beat. A sinus beat, PQRST, and then a broad beat. PQRST, then a broad beat. Okay, if you look at the broad beat for a given lead, lead 2, you can see the shape of this looks the same. The shape of this beat always looks the same for any given lead. So in lead 1, it looks like this, the same. In lead V5, it's positive with the deep S wave. So this is a broad beat because it's taking longer to conduct. It is coming from the ventricles. So it's called a ventricular ectopic. It's one beat, okay? So that's just one beat, and this is a ventricular ectopic. Because it's happening every second beat, we call this ventricular bigeminy. This is ventricular bigeminy. Okay, one beat. If now, okay, it's a different patient. If now we try to look at these beats, so say, for example, in lead 2, we have a P, QRST, broad beat, broad beat, broad beat, broad beat going along, several broad beats, but all these beats look the same. Yes, they're joined up, but they all look the same for lead 2. And again, when it happens again, this is broad. Okay, so this is now, in any given lead, they look the same. So this is now a several beats, or what we call a non-sustained VT, because it doesn't sustain. It stops, goes back into normal rhythm, bang, fires off again, back into normal rhythm, fires off again. Okay. So now we've got these broad beats where they all happen together. So there is no sinus beats at all. They are all broad. Okay. So now we have to look at this and see, it does remind me a little bit of left bundle branch block. Okay, because we've got this little R, and looks like it is this left bundle branch block, but no, it isn't, because look at our axis now. Our axis is very positive in inferior leads. So this suggests this is something coming from the top of the heart down, We now have positivity in V3, V4, V5, V6. So that is not a typical left bundle branch block pattern, but we have a regular, broad complex tachycardia. It's regular, the spacing between the QRS is the same, it's broad, the QRS is greater than 3 small squares, and the pattern is not left bundle because of the axis and the transition where it becomes positive. Okay, so this is a ventricular tachycardia. So so one beat would have been just one QRS, non-sustained would have been a few, several going back into sinus. Now this is sustained broad complex tachycardia. There is possibility here that that is a dissociated beat. That's a sinus beat there. That might be a sinus beat there. So the sinus node is firing like that. And it's possible that little bump there might be a sinus beat. So looking in V1 for dissociation to confirm it's VT. Okay, so we try to go through it the same way as atrial tachycardia. So we have a single beat, non-sustained, and now we have a sustained broad complex tachycardia. So I've talked about dissociation before, just remember, sinus node will fire at its own rate as if it's in sinus rhythm. It doesn't know the heart's gone into VT. The VT is beating at a completely different rate to the sinus node, but we can look for dissociation best in lead V1. I've talked again before about fusion and capture beats, when the sinus node may fuse with a beat in VT, or the sinus node will capture the AV node and penetrate down the conducting system to portray itself as a capture beat, a normal sinus beat. And then the VT circuit carries on. I talked about concordance. So here's a little sort of examples for you. So in ventricular tachycardia, when we have the chest leads and they're all negative, so this is all negative, this has to be ventricular tachycardia, can't be anything else. When the leads are all positive, like in this example, we have ventricular tachycardia. Again, in V1, there is not 2 bunny rabbit's ears. There's not 2 bunny rabbit's ears. So this is a VT when all the leads are positive. Okay, so let's go through some more examples. Are there any questions at all? Okay, so we have a regular broad complex tachycardia. Okay, there's a bit of an artifact here as the rhythm goes down. Okay, we know it's broad, the QRS is broad. Okay, it's regular, the spacing between every QRS is the same. Is there a delta wave? No, there isn't. Is this a typical bundle branch block pattern here? No, it's not. It's not left, it's not right bundle branch block. So we're thinking this is VT. So let's see if we can answer ourselves some of the answers. So is there evidence of dissociation? So I put little marks actually here that that's probably a P wave, that might be a P wave. So there may be some P waves going along to signify the sinus node firing at a rate that's different to the V's. Okay, so there could be VA dissociation. Are there any fusion or capture beats? Are there any beats that are looking fused? Yes, look at this. You've got a broad beat, and now you've got a fusion beat, which is a bit more narrower. It's not as narrow as a narrow beat sinus, but it's broad, but not as broad as the broad beats of ventricular tachycardia. So this beat is a fused beat. Are there any capture beats? Are there any beats on here that are narrow? Yes. Look here, there's probably a P wave with a narrow beat which captures. There's this capture beat here which is narrow, and that should match the ECG when the patient is back in sinus rhythm. But the VT otherwise carries on. Okay, there's evidence of fusion, capture, dissociation. This is ventricular tachycardia. Okay, another example. So we have a tachycardia. Is it narrow or broad? It's broad. QRS is broad. Okay. Is this a typical bundle branch block pattern? Okay, could be left. It's a bit small for left bundle branch block, but let's check. No, it's very positive in V2 already. So this is not, the axis is not left. So this is definitely not a left or right bundle branch block pattern. Is there a delta wave? So we're looking at on the isoelectric line, straight up, straight down. So no, there is no delta wave, straight up, straight down. Look at V1. Is there evidence of dissociation? Probably. This could be a P wave here. This could be a P wave here. This could be a P wave there. So you're getting an idea what the P wave rate is firing at a rate that's different to the VT. Yes, so there is dissociation. Are there any evidence of fusion and capture? It's possible this beat might be fused, slightly more narrower than this next beat before it. Again, that might be fused, is narrower than this beat before it. And this might be evidence of a capture beat, or another fused beat there. Okay, bit of artifact on that example. So this is another example of VT where you have dissociation. You don't have a typical bundle branch block pattern. You do not have a delta wave. Okay, going along, again, we have another broad complex tachycardia. It's a bit of slower VT now, but it's still regular and broad. Is this a typical bundle branch block pattern? This is definitely not. Okay, it's not typical right bundle branch block pattern. The R to the S is greater than 100 milliseconds there, very broad. Okay, and this is likely to be a VT. There's not a delta wave. Now we're looking for any P waves. You don't see any P waves there. Possibility. Can't see any fusion or capture beats really either, to be quite honest. Okay, so this is just another example of a slow ventricular tachycardia, and the pattern is not VT. So you always treat a broad complex tachycardia that's regular as VT. So we've gone through this before, just making sure. Small bunny rabbits here, big bunny rabbits here. This is right bundle branch block, and it could be SVT with right bundle branch block. VT is going to have a very wide R wave, and the R, beginning of the R to the deep S wave, or the start of the S, is going to be greater than 100 milliseconds. Okay, so we've gone through corresponding broad, regular, typical bundle branch block pattern, delta wave, VT corroboration, and we've gone through some pre-excited atrial fibrillation. So we're just in the final few ECGs. So we're going down the regular broad complex tachycardia route. We've talked about Wolff-Parkinson-White AF pre-excited. Again, pre-excited is another word for delta wave. You also need to think about AF with bundle branch block or aberrancy, polymorphic VT, torsades, hyperkalemia, and VF. So if we look at this ECG, we have a tachycardia, clearly. It's very broad. And when you look at the spacings between every QRS, it's definitely variable. Okay, it's definitely variable. Okay, so it's irregular, broad complex tachycardia. And if you look at every single QRS, it seems to have a different shape. They all look different. Okay, so each beat has a different form, as I call it, different form. Okay, and this is polymorphic. Polymorphic, poly, many, forms, morphic forms. So this is polymorphic VT, polymorphic VT. Okay. Another example of polymorphic VT, because within the lead, you've got it looking very negative, going very positive, and all beats look very different. It's irregular and fast. Some of the causes for polymorphic VT could be ischemia. So in this example, this gentleman's having an ST elevation, myocardial infarction, which goes into polymorphic VT, secondary to the inferior stemming. Other causes might be long QT, abnormal electrolytes, class 3 medications, catecholamine sensitive, and in normal hearts, you can get polymorphic VT. It doesn't have to be life-threatening. So polymorphic means many different forms within a given lead. Look at the given lead, V2, we have a tachycardia that's irregular, but the beats look different. Okay, I might have shown you this, I did show you this ECG during the antiarrhythmics lecture. So we have got another form of what we call polymorphic VT, but this is now sort of twisting around an axis. So you've got this axis here, these two axes It's almost like you're getting a towel and you're wringing out a towel, because it goes from being small, narrow, going broad, really, really big, and then back to being narrow again, and then broad and really big, going along, being narrow, this relatively narrow, and then broad again. So it's almost twisting around its axis. You can probably see it a bit better in this example: broad and tall, a little bit of narrow, broad again, small, broad again, small. So this is an example of torsades de pointe, torsades. It's a rhythm that obviously we don't like to see in relation to class 3 antiarrhythmics. It's a side effect. It can also happen in long QT syndrome and is the cause of sudden death in those patients with perhaps resulting ventricular fibrillation. So we can try and prevent it by using defibrillators and beta blockers in long QT patients, stopping any antiarrhythmics that might be dangerous. This is another example of your torsades, just on a single lead, very clearly now, much more twisting around the axis. It goes very broad. It is a form of polymorphic VT because each QRS looks different. Then it goes narrow before it then goes taller again and twisting around its axis. And this is torsades in relation to long QT. Another example of torsades de pointe, and there's some other causes there that I've mentioned already. A really spot diagnosis now. They have recorded a 12-lead ECG for this patient, which is interesting. So you can now see that it's very disorganized electrical activity, chaotic activity. It's not discrete. So the pattern is very small. I gather that here is a little bit more, 2 leads, yes, but generally over the whole 12 leads, it's a very narrow sort of window like that. Just, it's not discrete, it's chaotic. This is obviously ventricular fibrillation. Ventricular fibrillation. Okay, so we seem to have gone through most of all our rhythms. We talked about SVT with monobranch block, SVT with aberrancy. We talked about it mostly being right rather than left bundle branch block. The transition would be seamless between a narrow and a broad complex tachycardia, where you may see it where they've gone back into sinus and there's evidence of a narrow complex. With Parkinson-White, we've talked about going down the pathway back up the node, and there'll therefore be a presence of a delta wave. We talked about VT not being a typical bundle branch block pattern with VA dissociation and fusion and capture. Okay, any questions? So I've sent you the ECGs as well. If you want to take part in the Kahoot, I'll play the Kahoot now. I'm just going to load it up. Just need to log in again. I'm going to log in. Okay. So just, I know you're logged in there, but that's good. I know you've got the ECG, but I've got the ECG to show you. So this is for questions 1 to 4. I'll just let you look at that ECG first, please. Okay. Questions 1 to 4. Excellent. Yeah. So broad complex tachycardia, a regular rhythm. Very good. So you're trying to go down the algorithm to have a look. Well done. Question 2. Yeah, so there is not a typical bundle branch block pattern in V1. The bunny rabbits is the wrong way around. Okay, so you've got a big one, then a small one. Okay, so this is not a typical bundle branch block pattern. Yeah, so there isn't a bundle branch block pattern. Okay, it's a tough one, it's a difficult one, but looking straight up, straight down from the isoelectric line. Got to go from the isoelectric line. Straight up, straight down. This is not delta waves there. What is therefore the diagnosis? Yep, so this is VT. So remember then, you've got a regular broad complex tachycardia. You do not think this is right bundle branch block. So it's not bundle branch block or aberrancy. You do not say that there's no delta wave. This is not Wolff Parkinson White. So by definition, you don't have to look for anything else. This is VT. Is it VT? Okay. That's question 1 to 4. So now we have question 5 to 7. Question 5 to 7. Yeah, well done. So broad and irregular. So you're going down the right-hand side of the algorithm, broad and irregular. Yeah, I think it's flat. This is trying to get the right words here for the algorithm. You know, it's generally flat. Look at, you know, it's not a very, I don't think it's very tall. That's what I'm trying to mean by the question. It's a very narrow window. It's a broad beat, but the height of the QRS complex is within a narrow range. So it's still broad though. Yes, this is VF. VF. It's not torsades. Torsades is a bit more taller, then it goes smaller. So this is VF. Okay, VF. Finer. VF is a lot finer, is probably the word to use. It's finer compared to torsades. Okay. So questions 8 to 11, and then the next ECG, 8 to 11. So I'll let you look at that first. Okay, so that's that ECG, and this is the ECG afterwards. So the patient has that ECG first, and then this ECG afterwards. Look at the tachy ECG, narrow, broad, regular, or irregular. Yeah, so broad and regular. Let's have a look at that again. Broad. There's definitely a broad QRS there. And the spacing between every QRS is the same. Within a given lead, the heights of the QRS look the same as well. The heights look the same. And that suggests a regular rhythm. Regular and broad. It is. This is a typical bundle branch block pattern. We've got a negative in V1. We've got a left axis deviation. You don't have to, but it's supportive of left bundle branch block. It doesn't become positive, the tachycardia, until V5 and V6. So that would fit in with the left bundle branch block. Yeah, normal sinus rhythm. Last question on this bit. Yeah, so it was an SVT with bundle branch block because we had sinus rhythm. We've never had Wolff-Parkinson-White. There's never been a delta wave. Okay, so this is bundle branch block in SVT, but we know this is aberrantly conducted because then in sinus rhythm, the ECG was normal. There's the broad complex tachycardia. So let's just show you that on the ECGs. So in tachycardia, we go back to the tachycardia. It's regular, broad. Does it look like left bundle branch block? Yes. Negative, broad, negative in V1, positive at V5 and V6. Yes, and left axis deviation, supporting left bundle branch block in tachycardia. When the patient goes back into a normal rhythm, ECG is normal. There is no delta wave. This is not Wolff-Parkinson-White. So they're in a normal rhythm. There isn't a broad QRS here. Okay. Therefore, this is SVT with aberrant conduction because it looks like bundle branch block. And finally, this ECG for the last few questions, please. Okay, last few questions. Yeah, broad and irregular, very good. Broad and irregular, the spacing between every QRS is variable, so that means it's irregular. Yes, there is a delta wave. So this is where there's pure conduction down the pathway. There's another delta wave. There's just a half a delta wave there. There's another delta wave going from the isoelectric line in this example, going slurring it up. So you don't normally see it every single beat, the delta wave. You don't see it every single beat, okay? But there is definitely a delta wave. So this is pre-excited atrial fibrillation, okay? We do not have a typical bundle branch block pattern, so we can't say this is atrial fibrillation. The presence, AF with bundle branch block, okay? It's got the delta wave, so the pre-excitation is another word for delta wave, pre-excited delta wave and atrial fibrillation. This is not VT because it's irregular. Okay, well done. Any questions at all? Okay, thank you for joining in. I'll make sure I put it on Blackboard eventually if you want to review it. Thank you for joining in this evening. Take care, everyone. Oh, there's something in the chat. Is that questions or? Oh, thank you. Yeah, you're welcome. Thank you. Enjoy the rest of your evening, everybody.